Let's talk about treatments for keratoconus. I'm Dr. Motwani from Cornea Revolution. The main treatment for keratoconus that people hear about is corneal cross-linking. Corneal cross-linking strengthens the cornea. What it does is it creates more bonds between corneal cells to actually strengthen the cornea to stop progression. It really does not make vision better. We know that it can flatten the cornea a little bit, and by flattening the cornea and maybe flattening sort of that peak point where the cone is a little bit, it can decrease some of the astigmatism on occasion, but most of the flattening is just sort of getting rid of some of the induced nearsightedness from keratoconus. It really doesn't help the vision per se. So it stops progression, which to prevent cornea transplant. Scleral lenses are a big option. Scleral lenses are lenses that vault the cone, and they create a new artificial surface by vaulting the cone. And when you vault the cone, you also create a tear sandwich in between that fills in. So by creating a new artificial surface that's essentially filled up with tears and then irregular cornea underneath, you end up with a better refracting surface. They're great. Scleral lenses work beautifully. The upside of them is you can really recover vision, and that's the recommended thing after you actually get corneal cross-linking, is to have scleral lenses to recover the vision. Recovering the vision with scleral lenses does require you to be able to wear them, and about 30% of people don't find them comfortable, and that makes it harder. If scleral lenses are comfortable, they're a great way to recover vision. Okay. After that, the choices become different. The traditional ways to try to improve the cornea are a compression methodology. Essentially, you push the cone back down. You can use intacts, which sometimes insurances cover because they've been around so long. They're essentially plastic pieces that get inserted into the cornea, right, that actually push it down. And you can increase vision as in resolution on a chart, but intacts kind of are like, taking a belt buckle, a belt, and pushing in that belly. The problem is or a corset and pushing in a belly that's sticking out. Fortunately, the belly hangs over. So depending on how much it hangs over, that can lead to poor quality of vision. In other words, you get better on a chart, but you still see kind of multiple images, everything's still kind of blurry. You can make out the letters on the chart and improve, but the quality can be poor. So that's plus or minus. CTAC is a more specific form where they use corneal strips. They use strips of donor cornea to actually inlay into the keratoconic cornea to compress it down as well. And that can also be advantageous, that you don't have, for example, the light reflecting off the plastic in your eye, and it can absolutely increase the vision on a chart by significant amounts. But the problem is, again, you can't compress in the middle where you're looking through, and that's the downside. You still have to compress peripherally, and you still kind of got that belly hanging over the belt, if you will. Okay, so it's still a compression methodology, so that's a pluses and minuses of that. The other choices then become, well, what can you do with laser? Laser traditionally has been more prevalent in certain markets and less known in other markets. The people tried just doing a regular PRK, and that was just correcting the prescription. That was kind of plus or minus and didn't work so well. People have tried removing some of the aberration layer, lasering down through the epithelium, and then cross-linking. That has actually been a little bit better, but it still doesn't remove a lot of it. The epithelium probably holds about a quarter of the aberration, so it's not like you're removing all of it. The best methodology really has been to do topographic guided ablation. And topographic guided ablation maps the cornea and reduces in the center the abnormality. And then if you combine that with the part where you're removing the epithelium that's hidden, the aberration hidden by the epithelium, then you get the create protocol, which is something I do. But the point of these laser procedures is to try to help the central cornea, which is what you're looking through, which may allow you to get better overall vision. Okay, that's important because essentially compression therapies like Intac and CTAC are going off center, pushing down and hoping you can get enough of an impact in the center to improve vision. This actually doesn't, when you do laser, it doesn't care about the periphery as much. It's going after the center where you're looking through, and it's specific. Wavefront laser doesn't work really well for this. Topography guided laser is the methodology that must be used because it has a much higher resolution. What's the downside? The downside is it's not covered by insurance, so it's expensive, number one. Number two, you have to have enough tissue to do this. If your corneas are so thin, what are we talking about? We can go down to about, really, corneas of about 400 or so microns centrally, a little over 400. But let's say somebody walks in with a 300 micron, whoa, that's really thin, okay? Most corneas we can work with. On occasion, we do see, and these are even in severe patients, but you have to have enough tissue for where the correction is going to be done. Now remember, when we're looking at tissue maps, the central area is the thinnest, but that's not necessarily where the majority of laser is going to be done. You have to compare, because it's a segmental laser to make a more normal cornea, where tissue is being removed to where you actually have it. Two different things than just a thin cornea from someone that does a measurement and says your cornea is thin. Very different. So you have to have enough tissue. So all of this has to be looked at. Do you have the tissue to come out where it needs to come out? Second, you can have healing issues such as infection and everything, like you can with CTAC or with even with Intacs. But otherwise, it's been actually, when you combine that with cross-linking, that's been done for a long time, so it's very safe. But again, expensive, and number two, do you have enough tissue to have it done? That's the main thing about laser. So these are the current therapies. This is what we have. If you want to stop progression, you cross-link it. If you want to get better vision, you get scleral lenses. If the scleral lenses don't work for you, as in 30% of people, or you don't even want to do scleral lenses and you want to improve your cornea, then you have to look at compression therapies such as Intac or CTAC. If you really want to improve your visual quality as well as the number of lines you can increase, you can then look at a topography guided laser treatment along with cross-linking to freeze it into place after the laser is done.